Alright, this is going to be Pediatric Medical Emergencies, Pulmonary, Part 2. Pulmonary Pathophysiology. First disease we're going to talk about here is going to be croup. Epidemiology on croup. It's viral infection. Most common in children after recent upper airway infections. 50 new cases per 1,000 children during their second year in life. Incidence decreases substantially after 6 years of life. Typically occurs in the fall and the winter. Reoccurrence rate is about 5%. Pathophysiology of croup. Viral infection of the subglottic airway. And that would be this area here. Swelling and edema of the airway results in a barking cough or stridor. Distal airways may be affected by fluid accumulation, edema, or bronchospasm. And these are going to be the lower airways down in the actual lungs. Your glottic opening would be here. Anything below this can be affected by croup. Signs and symptoms. History and illness over the past 1 to 3 days. Fever, malaise, respiratory distress, and a barking cough. Management. Goal is to prevent airway obstruction, maintain calm, quiet environment, administer high flow oxygen in high concentrations. Humidified oxygen is probably going to be the best, but as it's tolerated. Moisture helps reduce the airway edema. Management. Give racemic epinephrine via nebulizer. Use steroids. Used with racemic epinephrine to prevent rebound swelling of the airways after epinephrine is worn off. Used as a primary means of swelling reduction is controversial. Examples of the steroids that we would use would be dexamethasone or budesonide or Symbicort. Conduct endotracheal intubation, and that's whenever all other options have been tried. Epiglottitis, 104. Epidemiology on this. Progressive reduction of cases since the mid-1980s, and that's due to the HIV vaccine. Changes in incidence in 1980, 3.47 cases per 100,000 people, and in 1990, 0.63 cases per 100,000 people. Traditionally an illness of children aged 2 to 7. However, we are now identifying them in more younger adults than children. Pathophysiology, typically bacterial infection, rapid onset of fever, glottic edema. It can also be viral, so this would be this area here. Upper airway obstruction from edema is possible with epiglottitis. Signs and symptoms: rapid onset of fever, sore throat, refusal to eat or drink. Positioning, they're going to be in a tripod position primarily, and drooling, stridor, respiratory distress. Management. Goal is to prevent upper airway obstruction, maintain calm, quiet environment, administer high flow oxygen in high concentrations, and then humidify this as tolerated. Give BVM ventilations in slow ventilation sequence. Conduct endotracheal intubation warranted only when impending airway obstruction, or if you have no air movement from this, that the airway is obstructed. Complete needle surgical crike if needed. Apply antibiotic therapy, and the antibiotic therapy is until identified or until the cultures come back. We should use wide spectrum antibiotics. Asthma. Epidemiology affects 14 million people in the U.S. in 2000. Adverse outcomes and deaths from asthma tripled between 1983 and 1996. Asthma in children. Children lose 10 million school years per year, and it costs. Parents pay estimated $726.1 million through loss of work days. Pathophysiology in asthma. It can be internal or external causes. Normal to edema. Increased airway resistance due to edema. Wall thickness by 1 millimeter. And in an infant, they have a smaller airway to begin with. So a 50% reduction of the lumen on the edema. Infant has additional resistance due to narrowing of the lumen. In the adult, it's about 8 millimeters to begin with, and then 25% reduction takes it down to about 6, which they can actually deal with it better. Disease of the airway, edema, mucus production, and bronchial constriction, and an narrowing of the airways is what asthma actually is. Signs and symptoms: respiratory distress, wheezing. Due to the swelling in the airway, the actual bronchial tubes do something called bronchospasm. Tachycardia, prolonged expiratory phase, because air comes in okay, however it will increase the expiratory phase. Air goes out at least 2 times, if not 4 times, the amount of time whenever they have asthma. Management goal is to treat the airway inflammation, reverse the bronchospasm, and correct hypoxia. High flow, high concentrations of oxygen. Pharmacology, and the pharmacology interventions we're going to take a look at here in just a second. BVM ventilations, endotracheal intubation, allow for prolonged expiratory phase. If you have these people on the vent, most people can a 1 to 2 versus inspiration versus expiration. On an asthma patient, 1 to 3, 1 to 4, it may take 4 times the amount of time to get the air out as it did to get the air in. And then air trapping can actually occur, which can cause barotrauma if you're not watching. Asthma-Pharmacology agents. Beta agonist is where we pretty much start this attack. They're often used with anticholinergics, which we'll talk about this guy here in just a second, and these two. Albuterol, Proventil, level albuterol. This one has more of a beta 2 response. This one gives us a beta 1 and a beta 2. This one here, still a beta 1 and a beta 2, which means not only will it increase our airway size by the beta 2 stimulant, but in these medications here, it'll also increase our heart rate. Same way with this. Terbutaline or brethine has a good beta response, beta 2 response. It also has a good beta 1 response. It increases our heart rate and contractile force strength. And epinephrine, not only do we get the beta 2, we also get beta 1 and beta 2 out of this, and we get an alpha response as well. Isoproterenol, big gigantic beta 1 response, which you'll get more increased heart rate and contractile force strength with isoproterenol. This is always a fine line whenever you're introducing the beta agonists. Is the increased heart rate and increased oxygen consumption going to throw them over the edge, or am I going to get ahead of the pathophysiology that's present? Should always be forethought in your mind. As far as anticholinergics, like ipratropium bromide, Atrovent, and atropine, very simply, this is the sympathetic nervous system, this is the parasympathetic nervous system. The beta agonists increase sympathetic tone. The anticholinergics block parasympathetic and give us more bang for our buck. Corticosteroids decrease swelling of the airway, but their onset time is generally 1 to 2 hours in the future at a minimum. Methylprednisolone, dexamethasone, solucortisone or solucortef, and then methylxanthanes or aminophylline. They actually form the active form of theophylline in the system. They increase cyclic AMP production and increase our sensitivity to catecholamines. So aminophylline does quite a bit. You can become toxic off of aminophylline though, very, very easily. Fat soluble, sticks around the fat. So what we get is we get a compounding of the toxicity levels if we aren't careful with aminophylline. Levels should be run continuously while on this therapy. Bronchiolitis, epidemiology, typically affect children between 2 and 24 months. Annual incidence, 11.4% in children under 1 year, and 6% in those aged 1 to 2. Each year, 4,500 deaths, 90,000 hospitalizations occur from this. 95% of children aged 2 have serologic evidence of a past respiratory syncytial virus or an RSV, and this is rampant in children. They go to daycare, they stay home, other kids that come in and out of the house infect them. RSV, they get it at least once a year they'll get the common cold from RSV, if not an upper respiratory infection and bronchiolitis, or the possibility of bronchiolitis. Pathophysiology on this, most often caused by the RSV infection of the lower airways, inflammation of the bronchial tissues, infectious byproducts accumulate in the lower airways. Signs and symptoms, slow onset of symptoms, tachycardia, tachypnea, fever, mucus production, wheezing, coughing, tightness in the chest. Management, goal is to reverse the bronchospasm, reduce the airway inflammation, correct hypoxia, identify and eradicate the offending pathogen. Administer high flow, high concentration of oxygen, use beta agonists, and this is a little bit controversial sometimes. Drugs and dosages are the same for asthma. Get ribavirin if you are the patient may be on ribavirin if they think it's from the RSV, and this is an antiviral agent. Conduct endotracheal intubation if needed. Take a conservative approach. If all other methods haven't actually been tried or facilitated, give them an opportunity before pulling the trigger on an endotracheal intubation. Foreign body airway obstruction. Epidemiology in 1998 in the United States, 3,200 deaths, 1.2 per 100,000 people from airway obstruction. Children under 4 log the highest mortality rate of 0.7 per 100,000. Pathophysiology, foreign body lodges in the airway in the supraglottic, glottic, or subglottic region. This is just before the opening, and underneath the opening. Full or partial airway obstruction occurs, limited or no ventilation. They develop hypoxemia, hypercapnia, high CO2 levels, and death if uncorrected. Signs and symptoms of a partial airway obstruction: difficulty breathing, stridor, drooling, and coughing. Complete airway obstruction: inability to breathe, talk, or cough. Management, as far as basic airway maneuvers, and these need to be got on very, very quickly. On an infant, back blows or chest thrusts. On children, Heimlich maneuver, finger sweep when the object is visual. Under advanced airway maneuvers, under direct laryngoscopy, McGill forceps, and if we cannot get a hold of it, pushing the object into the right main stem with endotracheal intubation should be considered. Needle or surgical cricothyrotomy. This ends part 2. If you have any questions, feel free to contact me. My name is Roy Smith, roy.smith@redlandscc.edu or smithr@imsa.net. Thank you.